Ayesha.
Yeah, can you see?
Yes, we can.
Assalamu alaikum, everyone. I'm very sorry I got late. Actually, I didn't know that I have to get the registration done first. So, should we start now?
Let me just introduce you very briefly to the attendees. Yeah, thank you very much, Dr. Aisha. It's, like you didn't need to register because you had a panelist Zoom link. So anyway, okay, let me just start. Okay, thank you very much, Dr. Aisha. We're honored to have you here today to talk about updates in diagnosis of blood cancer, standards and limitations. So Professor Ayesha Junaid is an accomplished medical professional. She's Program Director, Diagnostic Hematology since 2013. She has established and developed the postgraduate residency program at SIH and has over 10 CPSP Pakistan certified fellows to her credit. As a consultant hematologist, she is heading the sections of hematology and blood transfusion services at Shifa International Hospital since 2003. With an extensive over 20-year experience of tracing and tracking screen positive, apparently asymptomatic blood donors, Dr. Junaid is now in a process of publishing that yield of over 100,000 blood donors, a great contribution towards prevention of TTI and overall disease control. She has authored over 30 scientific papers, including a recent one in Nature on COVID-19. In addition, she has contributed 2 chapters in clinical laboratory practices in Pakistan, published in 2019, a combined venture of National Academies of Sciences of America and Pakistan, which has been translated in many regional languages. That's a wonderful job. Thank you very much, Dr. Aisha. All yours. Thank you.
Thank you, Dr. Fawzia, for giving me this opportunity to have a mutual learning experience today with your audience from more than STMU University. I feel honored and should, as we have already wasted 5 minutes in joining the Zoom meeting. So can you see this slide? I had this chat thing. So if during the next 50 minutes, if you have any question or query, you can write in the chat box. Is this the chat box? But I can't see. So, and at the end of the session, I would inshallah be answering all your queries and concerns. So my topic today with you is updates in diagnosis of the blood cancers, the standards and limitation. Can you see this slide, all of the audience? Wazir, can you see?
Yes, we can see it. Thank you.
Okay, let's start. Thank you. Let's start. As you all know, the blood cancers or leukemias, white blood cancer. Luke is actually referring to white, whereas once the blood turns white in cancer, that is the layman term for blood cancers. It's as you all know, I'm sorry, I don't know the level. If I use some term which is not very clear to you, you can raise your hand or put in the chat box, but I would like to make it very, very simple, understandable language. So this blood cancer or leukemia is actually a genetic disease, which, as you all know, is clonal proliferation of the precursor cells in the bone marrow. The blood is being produced by the factory, which is there in your soft bones, spongy bones called bone marrows. And once there is a series of genetic lesions in this precursor cell, it results in unchecked growth of these precursor cells. And mostly these cancers, the blood cancers, most of the time, the question is, what is the stage of the cancer? So all the cancers which originate from bone marrow or blood is actually stage 4 cancer. So these are pretty aggressive form of cancers, and at times they remain undifferentiated. But at times we can specify the lineage of the cell of origin, basically dividing the acute leukemias into myeloid and lymphoid malignancies. The recent research has put down more categories like histiocytic and megakaryocytic, monocytic, granulocytic, or erythroid leukemias, but mostly it is the disease which is differentiated into myeloid and lymphoid types. To make it simple, all cancers, like other diseases, were actually first categorized on the basis of the clinical history and physical examination. And it depends on the gadget we have. If we have a microscope, then we would we would divide it in the morphological features to the myeloid and the lymphoid type. Mostly the patients for acute leukemias or acute blood cancers, they give very short history, 7 to 10 days or more than a week's time, but not expanding to months or years, which is the case in case of chronic leukemias. So once acute cancer comes, it is usually the failure of the bone marrow and resulting either in severe anemia, which results in fatigue, or it comes with a high TLC count, leukocytosis, and multiple infections. And most of the time in children, the leukemias, they present as bone pains. So first, once we do not have a good laboratory service or diagnostic service, and we just have the clinical information, and we take the blood of the patient, or we take the bone marrow from the, mostly in adults, from the hip bone, or in case of children, we take from the tibial tuberosity or the knee bone, and we put the bone marrow, make a smear, good smear, and then stain it with simple lab stain, Giemsa and Leishman, and then we see it under the microscope. So the basic acute leukemia diagnosis was done by the clinical information and the histological feature of the abnormal cells, which we call as blast. And we would define them according to the cytometric details. If they have a rod-like structure, which is called an OR rod. On simple microscopy, we can say that these are the myeloid leukemias. And but the story is not that simple. It has been the case, and it unfortunately is still the case in most of our Pakistani labs, that on the clinical and histological basis, we define these as leukemias and we treat them. But the world has progressed much beyond that, and we have got genetic, genomics, and molecular characteristics of these diseases, which would define and give the precise definition of leukemia. So as we know that these are genetic lesions now, we should, the major category, 3/4 of these leukemias, they come from acquired somatic mutations of either a set of tumor suppressive gene or the ONCO genes. They are affected and the balance is tilted in favor of the tumor production, more proliferation of the immature cells. But 1/3 or 1/4 of these leukemias, they have actually germline mutations, which we say, for example, in Down syndrome and Lee-Froehlich syndrome, we found out that Lee-Froehlich syndrome, that these lesions they prone these patients to the genesis of acute leukemias much more often. So whatever the genetic lesion is, actually the outcome of the malignant transformation would alter the cell signaling or transcription or splicing, or there would be epigenetic factors which would actually manifest the clinical picture of the cancer. And now we know, with our more knowledge of the molecular genetics and more precise tools, that the things which were that simple on the microscopy were not that one group. It was actually a heterogeneous group. And if I make it simple, then there are certain genetic mutations which we call as pre-malignant states, and those are the initiations lesion. And later on, the FLT3, NRAS, RUNX1 like mutations, these are the later mutations which would result in the form of a malignant clone for blood cancers. Now, this we should know that nowadays the diagnosis of acute leukemia is not only to make sure that it is myeloid or lymphoid or what is the genetic lesion there. it is actually the prognostication of the leukemia as well. For example, FLT3 mutation and NPM mutations, they make these leukemias even more resistant to chemo induction and chemo intensifications. So right away from after the diagnosis, we have to classify according to the good prognosis, good, bad, and intermediate prognostic groups. Now, to start with the diagnosis of leukemia, as I have just narrated, that we need a precise definition of leukemia. It's acute leukemia. It is myeloid type. It has got any genetic lesion in the germline or acquired. But most of the time, we need the battery of cells should be searched, that we should be able to delineate de novo leukemias from the therapy-related or radiation-related leukemias, because they are right away resistant to the therapy. So once we diagnose leukemias in lab, or we have a patient with suspicion of leukemia, we need to define the history of the patient as well. If they have got some organ malignancies, or they have been treated for some autoimmune disorders by some radiation or by some cytotherapy, then those leukemias, they would not respond to the leukemias which would arise as de novo leukemias. Secondly, the diagnostic criteria should include the early relapses, because once the leukemia relapse, it is again something which is very, very refractory. So we should be able to diagnose the relapse of leukemia early, and we should be able to stratify it right away at the time of diagnosis into risk stratification. Then right away during the diagnosis, in this week also, we had a patient with acute promyelocytic leukemia, and he presented with in a condition like DIC. Once promyelocyte degranulate, they cause this excessive bleed from all the orifices. So not only the type of leukemia is important, the origin, how do they evolve. This is very important, that once the patient presents to the doctor, there are other oncological emergencies like tumor lysis syndromes. All those patients who have got very, very high count, like 3 or 4 lakhs, once you give them chemotherapy, these cells, they degenerate and they clog your capillary vessels in your kidneys, which results in acute renal shutdown. So the diagnosis of leukemia should include oncological emergency situations, maintenance, and the continuous treatment of acute leukemias is again very important. Now, around 2 decades back, there was a news from the scientific world that we have found the cure to the cancer, and that was like unlike to the other organ malignancies, most of the blood cancers, they were related to specific cytogenetic abnormalities. And as we are in search of a target therapy to undo the genetic lesion, so in year 2000, this discovery of undoing the genetic lesion of translocation 922, which was Philadelphia chromosome, was highlighted and marketed as the target therapy for cancer. But unfortunately, it was not a situation of 1 + 1 = 2. Very soon, after the launch of this drug, imatinib from Novartis, we came to know that the leukemias which were to be treated by these diseases were actually having other lesions as well, which were not that, we didn't have that precise tool to diagnose it at that time. 20 years back. So there were CML patients which did not have Philadelphia chromosome, and we labeled them as atypical or juvenile CML. Then we have seen the adult CML patients with different isomers of different molecular weight, and their clinical behavior was very different. So we need, besides precise definition, we need to be clear about the fact that the glaring lesion might not be the thing which would treating that would undo the leukemia. So now we have to classify the leukemia. Why we need to classify the leukemia? It's a global disease, and as we all know that now patient jump from one center to another center, from one country to another country, just to find the cure for the potentially fatal disorder. So now if in Pakistan, if somebody has been labeled as acute myelomonocytic leukemia, in Germany or in England or in Australia, that diagnostic criteria should be accepted and the patient should be treated and taken as that. So that is a global understanding of that specific type of leukemia. And nowadays we follow WHO 5th edition is out, and that was recent in 2022. They have revised it with more knowledge of genetic lesions, and they have classified clearly the lymphoid malignancies as separate categories, and the myeloid and the histiocytic dendritic neoplasm as a totally different category. And ICC classification is another classification which is globally accepted, and it is important to know about these two classifications once we talk about leukemia diagnosis. As I have just discussed it, morphology is the thing that once we take out blood or bone marrow and put the blood and make a smear and stain it and see it under the microscope, that step is called morphology, morphological features, cytology, histology, and the tissue architect. If we take out the piece of bone, which is called refined biopsy, and then we do all these immunohistochemistry on that. So that is all morphological and immunohistochemical basis on which we can define cancers. But as I have just narrated, that it also would depend on the history of the patient, how acute were the symptoms, whether the patient has presented with very high counts or as aleukemic leukemias. Aleukemic leukemias are the conditions in which the patient would have blast cells, some blast cell in the blood, but the bone marrow would be teeming with the blast, but it is so jam-packed that the blast cells are not coming to the periphery, and in that cases we would have cytopenias in the blood, but we would still have leukemia. Previously, the books write it as a leukemic leukemia. Let me see if we have some chat. Right to questions. Okay, Amrita. So let's go ahead. If you are very clear about whatever I'm saying, so I'll keep on going. But if you want to ask about anything, you can put it in the chat. So after doing the morphology, clinical attributes, we need to define very, very specifically the lineage. And I'll talk about it, about acute undifferentiated leukemias and biphenotypic bilineage leukemias. So that would depend on more precise tools. Cytogenetics in molecular features. So these are the 5 things on which WHO would, it would classify leukemias. So now overall, before we go to the details of specific subtypes, we need to know that we start with the cell which actually got transformed into the malignant clone, which type of cell is this, and then we define the family and class and then entity depending upon which immunomarkers are there, and then we define the subtype. So the precise diagnosis would depend on, but that is something very, very ideal situation. In Pakistan and in other countries where we do not have that much financial the patient is not financially stable and they just want a diagnosis to start the treatment. They don't have that much money. So we WHO this time has come up with the diagnostic criteria into essentials and desirables. The essential criteria are those criteria without which we cannot define a leukemia, we cannot define a cancer. Whereas desirable are those which would be helping these cancer patients in their further categorization into different prognostic groups. Now, these are the usual tools which we have. I have just explained to you CBC blood and smear bone marrow biopsy. Most of the time, the criteria which are written in ICC and WHO 5th edition, they say if you have blast equal to or more than 20, either in blood or in bone marrow. But whenever we ask our oncologist that you can straight away go to from the CBC, which we claim have blast cells, then you don't need to go for the biopsy. But here, traditionally, every oncologist wants a bone marrow biopsy to start with the leukemia treatment. Most of the time, we can jump from CBC to the flow cytometry, and we can avoid this invasive procedure if we have enough blast to be typed by flow cytometry. These three techniques are crude, special stains, immunohistochemistry, whereas flow is a technique which we use for the diagnosis of leukemia. And which would precisely define the clone. Whereas FISH and cytogenetics are mostly for at times for the to complete the diagnostic criteria, and then PCR and genetic testing. And nowadays there is a lot of noise about NGS incorporating the next generation sequencing into the leukemia diagnosis. But we have got some question marks here, not only because the finances or the laboratory technique is not that refined, but we know that the application of the NGS needs some original population-based profiling, which unfortunately we do not have at the moment. So keeping it simple, if you suspect on the basis of clinical features, if you suspect from the CBC and peripheral film that there are blasts equal to 20% and you are suspecting leukemia, the simple thing is to go for the flow cytometry and confirm it. But as this is an expensive investigations, the simple thing is that you go for flow cytometry and cytogenetics and FISH, which is again not very expensive. But this is what I just narrated as essentials. Whereas in desirable situation, you need to go for the genetic testing, which I would highlight now. Now, what is cytogenetics? Cytogenetics is actually, it's a technique in which this is called a karyogram. And this karyogram that we take the bone marrow or the blood of the suspected patient and we grow them in cell cultures. And then we do this once the mitosis is achieved by adding the growth factors and putting the cell into cell cultures, we halt this mitosis and we stain this mitotic banding into Gimsa banding, which stains the chromosome into dark and lighter bands. And this gives a gross numerical as well as structural abnormality of the genome, the whole genome. For example, if a suspected cancer patient would have 46 chromosome, and now with the karyotype, you can see the gross abnormality if there is a deletion or if there is transformation from one part. This you can see through the karyogram. And in blood, 15-17 translocation for one special type of blood cancer, that is promyelocytic leukemia, and for this 922 translocation for ALL, bad prognosis. So this is something which would aid you in the diagnosis of the leukemia, whereas this cytogenetics can help you define the bad prognosis in case of acute lymphoblastic leukemia. Now, in a different type of cancer, you would find that we have complex cytogenetic abnormalities in which if you would have more than two structural abnormalities in chromosome, then we would define it as adverse group. So this you can appreciate that now the blood cancers, they need to be diagnosed, as well as before starting the treatment, we need to give the risk groups. The second investigation, which is important and is prevalent in diagnosis, is FISH, that is fluorescent in situ hybridization. In this technique, what happens is that you take the suspected sample, blood or bone marrow, lymph node, and then just like cytogenetics culture, which are taken in sodium heparin vials. We take the sample in sodium heparin vials, and now we put it in the with the genetic probes. Probes are small segments of DNA which are fluorescently tagged, and if they would have complementary sequence in the chromosome, then they would go get attached with it, and then under the microscope, fluorescent microscope, you can find the abnormal signal as it is a sensitive technique, but definitely it is not showing the whole of the genome like the karyotype. The karyotype is actually showing you the 46 chromosome, whereas FISH is only for that segment which you have used as a complementary sequence if the mutation is there. But it is very, very precise, quick, much quicker as compared to the cytogenetics, which takes around 10 to 15 days. We can take out the FISH or fluorescent signaling as confirmation of the acute leukemias, which is very quick. Now, I would quickly go through the use of flow cytometry in acute leukemia diagnosis. This is very precise. This would tell you the clone and the malignant clone, what features it has, but it also has got its limitation. There are certain types of cancer, for example, early T precursor ALL, ETP-ALL, in which only one additional CD7 is there on the leukemic clone, and that would change the outcome of the patient. That would make the patient's outcome very poor, and it would prone to the patient is prone to have more induction failure, more refractory disease. So it is only can be defined by the flow cytometry. Similarly, the other types of cancers like acute undifferentiated leukemias or biphenotypic leukemias, in which the malignant clone is showing both the myeloid as well as lymphoid markers, as well as early TP-ALL, it is not possible without the use of flow cytometry. Flow cytometry is the technique in which you run these fluorescently tagged blast cells in an instrument called flow cytometer, and that gives a peak or clusters this in the form of each cell which has gone through this flow cytometer that is tagged, and that this is called scattergram. The scattergrams would show by the position of the cells and by the number of the cells and specific antigens. For example, this clone is positive for CD. I would show the markers CD7, which is ETP marker. So this clone is positive for that. So this is by the use of flow cytometry that you can, without which we cannot define mixed phenotypic leukemias as well as acute undifferentiated leukemias. Then there is another leukemia which is near early precursors, and this near early precursor does not have that resistant type of disease. This leukemia is quite responsive. So this is again the presence of CD5 marker on the malignant clone. So flow cytometry seems essential. It seems essential for the diagnosis of leukemia. As 20% of the AML, they co-express both myeloid and lymphoid markers. So you need to see these scattergrams to define it completely. But now the limitation about the flow cytometry is that at times your sample which you use for the flow, you cannot use the trephine or the bony specimen. So it's either the blood or the bone marrow aspirate. But if it is diluted, it would misguide you. It would show you that the bone is in remission. It is showing that the MRD is negative or it's less than 2%. Whereas once the same patients, once we did this bone marrow, we took out the refined biopsy as well. And that refined biopsy showed us the positivity of the lymphoid blast in the form of PAX5 positivity and TDT positivity. Quite a number of them, around 60 to 70% of the precursors were positive. So everything that counts it does not matter as long as the prerequisites for that technique is not used. If it is diluted, you would have wrong results. So as it is said that this is the man behind the wheel, which is important. No matter you would have sophisticated flow cytometry, until and unless if your sample is not accurate or appropriate, then you would end up in wrong results. Then comes the strength and limitation of the genetic material testings. As you can see that we have got PCRs, polymerase chain reactions, cytogenetics, and fish we have just talked about, and then gene expression profiling and conventional sequencing. These are the different techniques by which you can read the genetic lesions of leukemia more fast and more cheaper. But NGS, as in many hospitals in Pakistan, at least in Aahan and in VMTC, they claim that they have made the myeloid gene panels for our population showing acute myeloid leukemias. But I think that this claim is too early, because we need to define, we need to have more cancer patients in which we have defined the NGS to market these myeloid panels. But slowly and gradually, with the use of artificial intelligence and methodologies which would end the I would say the gold standard would be a POC test, which would just on the patient bedside would tell which type of cancer they have. But that would take in reality, that would take some time to get into the market. Now, previously, in order to define the whole genome, the mutations which were actually shown to be directly related to the outcome as acute leukemias were actually were only the forefront lesions. Now we know by our knowledge of studying the whole genome that there are other lesions sitting behind it or sitting above it, which would be showing the outcome as acute leukemia. So I remember once I went to LA, there was a big room they got us visit that, and that they said that this is a segment sequencing room for sequencing the human genome, and the sequencing of the entire genome on that technique would take 60 years, but rapidly within 10 years, now the next generation sequencing has come up, and that has got high throughput, and the probabilities from the research to the clinical usage is now seems a reality. But as I told you that we need to define the population screening, and we need to do our subcategorization of our leukemias before we use successfully these genetic lesions definitions. What are the challenges in using NGS for routine use in acute leukemia diagnosis? The best choice would be the one which is readily available and that has the impact on the management of leukemia. The introduction of NGS is there, but still we need time to define the single gene or panels which would affect the individual patient management. At times, the blood malignancies are showing lesions in whole exomes, or there are bigger lesions. So what I can see is for the next 5 to 10 years, NGS would not be that, is a very good tool, but because of the financial constraint and for the technical hurdles which we can implement. We need to work on NGS availability in the clinical labs. Now, before I conclude, I would like to re-emphasize that cancer, especially the blood cancers, once we see it as a 1:1 lesion, and as our goal is to form a target therapy which would undo the lesion of the cancer, we need to go for a multi-targeted approach. It cannot be only one gene which would help us. Adding complexity to this ground reality is the pharmacogenomics, which is again running parallel to the use of these genetic tools. And now we know that the same chemoinduction does not work on the same myeloid panel, which we have read from the NGS, and that is because of the genetic makeup, and the drug does not affect the person that much, and the variability can be as high as 1,000-fold. Now, as we are progressing towards the antidote to cancer, and we now know that beside chemotherapy, beside targeted therapy, now immune therapies are coming up in markets, and now we want to knock down the cancer before it forms a mutated protein. So now the target is not mutated protein, rather it is that the target is the actual genetic lesion, and 1/3 of the clinical trials has shown complete remission by the use of menin inhibitors. That is the latest in the treatment of in management of cancers. There are, I think, 3 questions. What is picture in leukemia blood? Biomarkers of leukemia, I mean to say. There is a question from Dr. Anila Durrani. Assalamu alaikum, Dr. Anila. By your query, what I get is, do you from the blood, if you want biomarkers of leukemias, that would be something chemical. I think no, we do not use in the leukemia diagnosis right away some biomarkers which would just like the biomarkers as CEA or your PSA, but for leukemias we do not have journal biomarkers. Does that satisfy your question?
I'm not sure if she's there listening to you, Dr. Ayesha. Dr. Ayesha, like okay, so she says yes. In continuation to that and your talk, you did mention some CDs, yes, CD7, CD, other CDs. So when do you use those biomarkers?
No, that is Fauzi, that is very specific for ALL. But
Right.
what I think Anila wants to ask is a general marker for leukemia. That is for the lineage specificity, and that too would not be from the blood as such. You have to go for the blast, and then you tag the blast with the monoclonal antibody for some time. So directly from the blood, you cannot get the
Right.
what I get is biomarker is just like we do the PSA thing from the blood chemistry, the plasma, that is not yet available.
Okay. Okay. So Dr. Ayesha, yeah, that's wonderful. You know, I learned a lot from this talk. Yeah, please keep on doing this, you know, every now and then, just to refresh our memories.
But, yeah.
I have okay, thank you. A couple of questions I had, you know, what sort of stats do we have from Pakistan? Like how many patients with like adults or children did turn up with ALL or other types of leukemia, let's say in Shifa, and then we can talk about Pakistan.
Yeah, the tumor registries at national level should be done. Though we have started at Shifa for 2 to 3 years for leukemias, but it should be, the answer to your question should be a national registry of leukemia, which unfortunately is not there. Each center like Shaukat Khan, Murad Khan or Shifa, they are doing it at their own. The patients who are presented to their departments or their hospitals. But one thing I can tell you for sure that in Shifa, we have got a lot of Afghani patients in population, and although all the blood cancers are decade earlier in presentation in these patients. For example, in myelomas, we read from the Western books and from American guidelines that these are the cancer in 70 plus years of age, but here we see them in 40s. Similar is the case with chronic myeloid leukemia. We see them in early 20s. They are the very, I would say, Philadelphia positive chromosome, Philadelphia positive CMLs. So that is very, very surprising that our cancers, they appear, so maybe the exposure to the carcinogen, the radiations, the pollution which we have got much earlier blood cancers, and our population, I would say acute lymphoblastic leukemia in Pakistan is the most common malignancies in children.
So you just mentioned Afghan. Is it, yeah, is it because, you know, we're based in the capital territory, like Islamabad, and that is why a lot more Afghan patients present to this hospital, or do you find it more like nation, like across Pakistan? Do you find more?
No, the entry points like in Peshawar and in Islamabad, you would have more Afghani patients with Hodgkin's lymphoma, with NHL, with acute leukemias, myelomas. But I think in Karachi and in Lahore centers, the entry of these Afghani patients is somewhat restricted. So most of the leukemic patients to Pakistan, they are through Peshawar and Islamabad.
Right, but you know, you said that, you know, in Shifa, because, you know, we have more Afghan patients presenting with leukemia. So I'm just talking about the overall number you suspect among Pakistani population. I know, I agree that we don't have a proper registry, but in your opinion, do we have a lot more leukemia patients in other parts of the country as well?
Fawzia, we have our annual PSH meetings and PAP meetings, which is Pakistan Association of Pathology and Pakistan Society of Hematology. And in that, we do present the national data, and it's a sharp, steep increase in leukemic patients reporting to these centers. And definitely in other parts of Pakistan, definitely beside Islamabad, Peshawar, we have got a sharp increase in leukemias as we have in other blood organ malignancies.
Oh, that's very sad. And do we have any clinical trials up and running in Pakistan?
We have recently started, Dr. Yasmin has started some clinical trials. We are part of, Shifa is part of those clinical trials. But I think Afghan is also a part of international clinical trials on leukemias. I'm not very sure about Shaukat Khanam. I'm sure वो करते होंगे जरूर उसमें. But yes, we should be part of all the clinical trials because our genetic pathogenesis is different
Yes.
from them. And most of the time, our relapses and resistant disease is more as compared to the foreign patients.
Yeah. Okay. And do we have any other question?
Yes.
Let's see. Not really. Anybody would like to ask any question? No raised hand.
Okay.
So I think that's all. Thank you very much, Dr. Ayesha.
Thank you for giving me this opportunity. I'm really grateful. Thank you.
Take care.
Thank you.
Yes. Yeah. Take care. Good afternoon.
Good afternoon.